Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarnet serves as a digital partner for this event, and the focus of today's session is general anesthesia. Now, I would like to invite Dr. A L Meenakshi Sundaram, sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former national vice president of the Indian Society of Anesthesiologists and has held key positions, including governing council member, president, and state secretary of the ISA Tamil Nadu state branch. Now, without any further delay, over to you, sir. Thank you.
Thanks, Clarnet. So today I'm happy to welcome all of you for the 38th webinar of Puthukkottai Bhudhan second edition. That means we have already conducted 52 editions weekly, uninterruptedly, 2 years back. Then after taking a break, again we are doing it, and fortunately I have been assigned as academic chairman. So this is the 38th webinar we are conducting. The 37th webinar was conducted on Saraswati Puja, October 1st. As Clarnet is based in West Bengal, where Durga Puja is popular, they even wanted me to change the date because they were worried about the participants. Everybody will be in Puja, they said. But I was telling this is an academic event. That too, it is coinciding with the Saraswati Puja. So we have to conduct it come what may. Because last time also we have done that. It is every Wednesday, it will be there fixed. And to my surprise, 875 people attended the webinar on ophthalmic anesthesia, which was held on Saraswati Puja. That ophthalmic anesthesia has so many peculiarities. One, ophthalmic anesthesia is not much concentrated by the anesthesiologist. But the participants, except that PG, all three are international speakers. And because of them and the curiosity of ophthalmic anesthesia, 875 people attended. And another peculiarity is the PG is Dr. Ranjita from MES Medical College, Perindalmanna, Kerala. And next speaker is Dr. Rases Diwan, who is a ISA National Governing Council member. He is from Ahmedabad, Gujarat. Then the third person is Dr. Venkataraj Hadigal. He is from Telangana, Hyderabad. And the moderator was Dr. Jaychandran from Shankar Nethralaya, Tamil Nadu. So it was a pan-India webinar. And again, now the participants are from Puducherry, JIPMER. And that first speaker is going to be Lakshmi Prasanna, the postgraduate. And she is a third-year resident in JIPMER. She has studied her UG in Kakatiya Medical College, Warangal. So what I want to convey, she is having two legs, one at AP and another at Puducherry. One state is a hottest state, and now she is in a seashore. And her extracurricular activity is dancing. I think she is a good dancer or not. She is interested in dancing. Now she is dancing. In due course, her husband is going to dance to her tunes. Why I am telling that? Madam is waiting for that wedlock, and she is a prospective person, and many people will be seeing this. And the madam's phone number is with me, so I can help. So I invite Dr. Lakshmi Prasanna to be a faculty in Pudukkottai Bhudhan, and it will be followed by Dr. Sekar. Dr. Sekar is a MD DIPMER graduate, because now in Tamil Nadu we value DIPMER more than MD, stating that MD, the qualification may be depending upon the internal examiner. So he has completed as DIPMER also. So he has done his MD from PGI Chandigarh. So that Chandigarh it itself is a prestigious institute, and he has done a fellowship also in solid organ transplant. So I think liquid organ transplant is blood, and a solid organ transplant is liver, kidney, like that. So he has done a solid organ transplant. Now he is working as an assistant professor in JIPMER, but previously he was assistant professor in AIMS, Kalyani, West Bengal, and he is a fellow in liver transplant anesthesia in a prestigious institute, Max Hospital, Delhi, and he was a senior resident in PGI, Chandigarh, and his areas of interest, naturally, he is interested in transplant anesthesia. But in JIPMER, whether he has the opportunity to do that or not now, I don't know, because that depends upon the institution. And in addition, he is interested in point of care ultrasound. And as an anesthesiologist, he is interested in swimming. So I used to say anesthesiology is like swimming. You can adapt to any style, regional, general, now block, whatever it is. Same way in swimming, you can opt for a butterfly or a freestyle or a breaststroke or a reverse stroke. But the intention is you have to reach the other shore safely. In anesthesia, the intention is you have to keep the patient safe, whatever may be your style. So he's a good swimmer, and he is interested in playing badminton. And I think his hobby is reading books. I don't know whether it is anesthesia book or not, but he's interested in reading books, probably novel and stories. And he is a good graphics creator. Whether in the slide he is going to create that or not, we have to see. And it will be followed by Srinivasan. Srinivasan is done his undergraduation in Stanley Medical College, where I served as dean for 11 months in Chennai. So he has done his MD. He has also done DIPMB and PDCC also in critical care. He has done a postdoctoral course in critical care, and he has done his fellowship in JIPMER, and he is now serving as assistant professor JIPMER. So he has studied there, continuing there, and his interest in pediatric anesthesia and critical care. Actually, pediatric anesthesia itself is a critical care, and he is interested in critical care. He has devoted his life to only anesthesiology. So he is not having any extracurricular activities because he want to be 100% anesthetist, because a critical care person cannot devote time much for relaxation or enjoyment. So he is doing it practically. And to control these three stalwarts, which we could not do, we need a person from JIPMER. He is an additional professor, and Dr. Mohan, who happened to be a best friend of mine. But only one difference, even though he is a best friend of mine, he is intelligent. So he was not influenced by my behavior. And he is a member, ISA member is common, Indian Society of Anesthesiology. But he is a member in Indian Society of Study of Pain and the Research Society of Anesthesiology and Clinical Pharmacology, RSACP. Only tough members will be there in RSACP. Like another Puducherry man, Dr. Parth Sarvi, he is also a member in that. And Dr. Mohan is having so many publications to his credit. So both national and international publications, he has published 11 papers. That speaks a lot about his credit. So I invite all of you to be in the scientific proceedings. And I thank Dr. Lenin, HOD JIPMER, for donating these people for our 38 webinar. Now, as I said, by 6:10, I will be handing over to Dr. Mohan. I said, now it is 6:09. Mohan sir, please take it forward.
Thank you, sir. First, I would like to thank you for the opportunity, sir, for moderating this session. Actually, only after we were asked, I saw a few of the previous webinars. I was really impressed with the topic selection, the way things were presented. It's really useful for upcoming anesthetists, PGs, and even for faculty. We have a tendency to go only for the advanced stuff. We forget that we need to maintain the basics. So this webinar is really useful. So let's start with the first topic, Thai by Dr. Prasanna Lakshmi. You can start, Dr. Prasanna. Dr. Prasanna?
Yes, sir. I'm sharing my screen, sir. So good evening, everyone. Myself, Dr. Lakshmi Prasanna, Junior Resident from JIPMER. So firstly, I'd like to thank Meenakshi sir for the kind introduction. And also I'd like to thank Dr. Lenin sir for giving me this opportunity to present here. So the topic for today's presentation for me is going to be on thiopentone. I'm going to revisit the pharmacology of the thiopentone and also teach the lessons what thiopentone taught us for modern practice. So in this session, I'd like to touch upon the history, the chemical structure, pharmacokinetics, mechanism of action, pharmacodynamics, followed by comparing the old gold, which is thiopentone, to the newer standard, propofol, and also the modern practice. So starting with the history, thiopentone, the barbiturates were discovered in the early 20th century. The first barbiturate to be discovered was hexobarbital, which was causing loss of consciousness within 1 brain-arm circulation time. Whereas the thiopentone, which is also known as pentothal, it was introduced in 1930 by Waters and Lundy, which marked the beginning of so-called barbiturate anesthesia era. It was once a universal induction agent, which was there in almost all the induction rooms of anesthesia. Now it was largely replaced by propofol. So a small question to all of us. So is the thiopentone is obsolete now, or it still has any clinical relevance as of now? So I'd like to say yes, it still has a clinical relevance and it's still used in certain conditions, which I will be explaining you in the further slides. Coming to the chemical structure, barbiturates are basically barbituric acids, which are formed by a benzene skeleton, which are an acidic in nature, and they are usually present in a keto form. Keto form prevents the formation of salts by the acidic acids. We need salts because per se we cannot inject acids into the intravascular circulation. So we need to convert them either into alkali form or a salt form. So to facilitate the salt formation, the keto form has to be tautomerized to enol form, which facilitates the formation of salts. So the keto-enol tautomerization facilitates the formation of salts. Coming to the barbiturates, there are basically two classes of barbiturates that differ by the presence of either sulfur atom or the oxygen atom at the second carbon ring. If it is the sulfur atom, they are called as thiobarbiturates. If it is an oxygen atom, they are called as oxybarbiturates. The anesthetics or the sedatives or the hypnotics which are available under the barbiturates class were thiopental, thiamylene, and the methohexitol. So how they differ in the chemical structure? So conferring the hypnotic potency or the sedative potency, it is because of the allyl or the alkyl group which is present in the C5 carbon. The amount of the alkyl group is directly proportional to the sedative effects of the drug. Whereas the methohexitol, which is a gold standard drug of ECT and also friend of thiopentone, is having an excitatory effects. It is because of presence of methyl group in the N on the nitrogen atom, which is replaced by the C1 carbon. Coming to our parent molecule, thiopentol, as I said, it belongs to sulfur barbiturates and it has an alkyl group at the C5 ring, so it is having a sedative or the hypnotic effects. Whereas the absence of methyl group in the nitrogen atom renders it a non-excitatory effect of thiopentol, which is in contrast to the methohexitol, which is having an excitatory potential. Next, coming to the pharmacokinetics of the thiopentol, starting with the distribution. Because of its high lipid solubility, it is rapidly taken up by the brain, and its short duration of action is not because of elimination from the body, it is because of redistribution. So the concept of redistribution has been taught to us by thiopentol. Whereas with the repeated doses or the prolonged infusions, it was causing prolonged recovery because it's getting accumulated into the fat. So repeated doses or the prolonged infusions was saturating the fat compartment, which is causing prolonged recovery. Coming to the metabolism, per se, thiopentone entirely gets metabolized in the liver with the help of hepatic microsomal enzymes. Not only that, it also induces the hepatic microsomal enzymes. So it is contraindicated in a situation called acute intermittent porphyria, in which this thiopentone induces ALA synthetase enzyme and increases the amount of porphyrins in the blood and can precipitate a porphyria attack. As it gets metabolized in the liver, it gets excreted into the bile followed by urine. So which highlights the importance of the hepatic metabolism for the thiopentone. And also the thiopentone introduced the concept of elimination under two headings. Either it is eliminated based on perfusion limited or it is capacity limited. Perfusion limited, as the name says, it's the amount of drug which is perfusing through the liver, which is important for its elimination. Whereas capacity limited tells that it is not only the perfusion, but it is also the capacity of the microsomal enzymes which are important for its elimination. As the thiopentone, which is having a very low hepatic extraction ratio, depends more on the capacity of the enzymes to get its metabolization done, not per se on the blood flow. Coming to the half-life and the clearance, as I already said, its redistribution half-life is 5 to 10 minutes, whereas its elimination half-life from the body is 12 hours, attributed to its very low hepatic extraction ratio. From this, the concept of context-sensitive half-life has been emerged. So thiopentone is a teacher which has taught us what is the concept of redistribution and what is the concept of context-sensitive half-life for the future anesthetics or the further anesthetics which has been prepared, taking the advantages and also the disadvantages of the thiopentone into consideration. Coming to the mechanism of action of thiopentone. Thiopentone exerts its action primarily not only by potentiating the inhibitory neurotransmission, but also suppressing the excitatory neurotransmission. So it acts on the GABA A receptors, facilitating the chloride ion channel opening, followed by potassium influx, causing hyperpolarization, preventing the depolarization of the nerve impulses. At the low concentration, thiopentone enhances the effect of the endogenous GABA, whereas at the higher concentration, it directly activates the GABA receptors. Not only this, it also inhibits the excitatory neurotransmission by antagonizing at the glutamate receptors, especially the AMPA subtype. So this dual action, both by facilitating the inhibitory pathways and suppressing the excitatory pathways, contributes to the anesthetic and the sedative effects of thiopentone. Going forward, a pharmacodynamics of thiopentone. What a thiopentone drug does to the body. So let us start systematically. First, let us talk about brain. The CNS effect. It decreases cerebral metabolic rate of oxygen consumption, and it is a very good neurovascular coupler. So by decreasing the oxygen consumption, it decreases the cerebral blood flow. Not only that, it also maintains cerebral perfusion pressure because it maintains autoregulation. So because of this property, it confers neuroprotective effects to the brain by the following mechanisms. One is by Robin Hood effect. We can remember Robin Hood as a person who takes money from the rich and gives to poor. Same, thiopentone takes the blood from the non-ischemic areas and gives the blood to the ischemic areas, thereby preventing the ischemic injury. And it also prevents the free radical damage and also the excitatory and it also prevents the excitatory hormonal play in the brain. And the termination of drug effect in the brain is mainly by redistribution. And it also has more context sensitive decrement time because of its accumulation into the fat. So which is not favored for the prolonged administration or prolonged infusions. Coming to its next effect on CVS, it decreases the sympathetic tone, thereby it decreases the inotropic action of heart and also causes vasodilatation. But it preserves the baroreceptor sensitivity, which causes increase in heart rate, which is in contrast to the propofol, which blocks the baroreceptor sensitivity and it won't cause increase in the heart rate. But patients without adequate compensatory mechanisms, such as severe hemodynamic instability, shock, or any hemorrhage conditions, this thiopentone administration can cause serious hemodynamic depression. Coming to the next organ, which is lungs, respiratory system. It causes dose-dependent respiratory depression. It decreases the minute ventilation. It also causes a phenomenon of double apnea, whereby initial administration of thiopentone causes a fast apnea, followed by few breaths. It is because the drug has been redistributed, and then followed by the second apnea because the drug has not been eliminated from the body. and it causes decrease in the ventilatory response to both hypoxia and hypercarbia. Whereas laryngeal reflexes are not blunted by thiopentone, so which is contraindicated in the patients who are having reactive airway. The other effects of thiopentone, as it smells or tastes garlic or onion, and it causes tissue irritation because of its high alkalinity, and its friend methoxysterol, as I already told, has excitatory effects, which was once a gold standard drug for ECT. Coming to comparing the gold versus the newer generations. So the newer generation hypnotics or the anesthetics have been originated by keeping advantages of the thiopentone and also by changing the disadvantages of the thiopentone and then formulating a sedative or an anesthetic agent. Coming to basic, so there has been a basic change in the structure of the drug. So as a barbiturate, as I already told, it is a barbituric acid, which is an acid form, which prevents IV administration. So this has been changed to alkyl phenol, which facilitated the IV administration of the drug without any reconstitution. Whereas the appearance, a thiopentone is available as only as a yellowish powder, and it is highly alkaline solution with a pH of 10 to 11. Whereas the propofol, which is now available, is now available as a white emulsion, which prevents the reconstitution thing. But and also the pH is not highly alkaline, so it facilitates the IV administration of the drug without causing much irritation. And but there is a but here, but it causes pain during injection because of its emulsion form or the soybean oil which is present in it, which is causing pain during drug injection. The onset, which is the main advantage of the thiopentone, has been incorporated in the preparation of propofol also. Both are rapid onset. Whereas the main difference comes in the recovery phase. Thiopentone was causing slow recovery after the prolonged administration, whereas propofol was causing a rapid and the smooth emergence, which is causing a better recovery profile for the patients who are undergoing the ambulatory anesthesia. Not only that, it also has a marked antiemetic property, which also increased the patient comfort. And in the anticonvulsant use, thiopentone still holds a place in the ECT room where it decreases the seizure threshold, whereas propofol is placed at the extreme end of the spectrum in the ECT room because it increases the seizure threshold. Next, coming to the metabolism, as we know, thiopentone was having delayed metabolism, so which was not allowing us to use it as a prolonged infusion, whereas propofol, to make it as an added advantage, not only it's having an hepatic metabolism, it also has an extrahepatic metabolism. So it used lungs as also an extrahepatic source of elimination. So the prolonged administration or an IV infusion was possible with the propofol. Coming to the cost availability, thiopentone is inexpensive, and the reconstituted vial of the thiopentone can be used for 1 week if it is refrigerated and if it is not exposed to CO2. Whereas the propofol, if once opened, has to be discarded within 6 hours because of its constituents. There is the high chances of contamination with the bacteria. So coming to the current status of thiopentone now, it is historical, but educationally it holds a place, and it's also still used in certain places, which I'll be telling you next. Whereas propofol, because of its a better recovery profile and an added antiemetic agent, and which also facilitates prolonged IV infusions, because it's the most common induction agent used now. So in the modern practice, thiopentone is still used as an IV induction agent when the resources are limited. As I told you, 1 vial can be opened for a week, whereas propofol, it has to be discarded after 6 hours. In the ECT, it is still preferred as a drug of choice in the ECT because methoxysterol is not available now because it decreases the seizure threshold, and it has a neuroprotective effect. It decreases the ICP and it causes EEG silencing, thereby producing the neuroprotectory effect in the brain. And also the concepts of redistribution, the context sensitive half-life has been taken as a base for formulating the TCI pumps and the TIVA infusions, which are most commonly used now. And also in the refractory status epilepticus management, where all the anti-epileptic drugs has been used, like midazolam, fosphenytoin, levetiracetam, everything has been used. Then comes our drug, the thiopentone. By causing EEG silencing, it can abolish the refractory epilepsy in the status epilepticus patient. Coming to the rapid sequence induction, it is the drug with which the RSA has been discovered, or RSA has been defined with thiopentone. So lastly, I'd like to conclude that thiopentone may be old, but it still has a pharmacological wisdom to teach to the modern anesthetic science. So I'd like to end my session with this. Thank you. Thank you, sir.
Thank you, Dr. Prasanna.
Thank you, sir.
It was a very good presentation. You covered all the topics quite well. And Meenakshi sir, you must have noticed her dancing skills, her body language.
Yes. We have seen that.
I have always wondered, with thiopentone, there is always a footnote about what we do in case of an accidental intra-arterial injection. It always comes. We always read about what to don't remove the IV line, injection of lignocaine. I always wondered why. The thing to understand about thiopentone, whatever complications can happen with an induction drug has been well studied with thiopentone. We say there are better drugs now, but what people should understand is that there is a reason why thiopentone has been used for decades. It's almost for a century. It has been the primary drug, and there is a good reason for that for it. It's a wonderful drug. The main advantage of the other drugs, it's not just the hemodynamic stability. It's about the titerability and also the smoothness of induction. That's how propofol with thiopentone. Otherwise, thiopentone is wonderful drug. We say thiopentone is irritant because of its high pH, but I have rarely seen patients screaming in pain while injecting thiopentone. But propofol is where a lot of people complain of pain, and we keep doing studies, how to decrease the pain. So, and as Dr. Prasanna pointed out, all the things like say acute intermittent porphyria. I don't know how many of us have seen such cases, but we always say it is contraindicated in acute intermittent porphyria. It's a reminder for us that diseases in patients can affect uh, uh, how the drug acts, the adverse effects, and also so many advantages of thiopentone. We have learned a lot from thiopentone, and whatever new drugs come with the basic information we have learned from thiopentone. Okay, we will go to the next topic now. Dr. Sekar. Dr. Sekar will be talking about rapid sequence induction. Sekar?
Yes, sir. Good evening, sir. Good evening, everyone. So, introduction has been given earlier. Thank you, ISA Puducherry City branch, for this opportunity. So now I am moving on to the topic. I shall share my screen. Yeah. So the topic given to me is that the art of rapid sequence intubation, and how to do and safe and effective airway management with rapid sequence induction and intubation. So disclosure, I don't have any potential disclosure to declare. So coming to the history part, to start with how the RSI was started. So it was in 1946 when he was a doctor. He is an obstetrician come cardiologist, Mendelssohn. He described the aspiration in the obstetric population. So eponymously, it was called as Mendelssohn syndrome in the obstetric population. So people were struggling to manage the airway in the obstetric population. There was a lot of incidents of Mendelssohn aspiration syndrome, which led to the lot of deaths in these obstetric population. So they were struggling to manage. So during that time, I'm not sure whether they have used the adequate muscle relaxations or adequate induction doses. I'm not sure about that. So it is almost after 15 years, the Selig and Lond, who first suggested the use of cricoid pressure at induction. but the use of muscle relaxant was in practice in 1950s as well. So maybe it was the inadequate dosage that also led to the aspiration during the intubation. And the problem still continued to exist till 1960s, and they found that in addition to the induction and muscle paralysis, the cricoid pressure also helps to prevent the aspiration. In around the 1970s, the term rapid induction and intubation was introduced. It was published by Step and Suffer, who first described the term the rapid induction and intubation as a new method for the prevention of aspiration during anesthesia induction. So the Mendelssohn, the Suffer, who described the classical rapid sequence intubation, consists of 5 sequences, so which included the pre-oxygenation and followed by prefixed administration of doses, induction agents as well as the muscle relaxants to paralyze, to induce a profound paralysis, followed by application of cricoid pressure. It starts from the induction, before induction, and it continues after the paralysis during intubation as well. And they were very sure that they are very strict about this point, that they should avoid the mask ventilation, and the tracheal intubation should be done within cuff endotracheal tube, and the positive pressure ventilation should be resumed only after inflating the endotracheal tube. So this was a classical sequence what they have described during that time. So what is the goal in the rapid sequence intubation? So basically, we want to place the endotracheal tube to prevent the aspiration in a patient who is at risk of aspiration. So the time to place an endotracheal tube, it will be in a very short time. So we have to place it as soon as possible. So we have to achieve this optimal intubating conditions rapidly. That is the main goal of this rapid sequence intubation technique. So this minimizes the length of time between the loss of consciousness after induction and to the securing of the cuff endotracheal tube. So this is the major goal. So while we come across the going deeper into the topics, we will be discussing again the same points. So we will get a more understanding about this. So about the next one, what are the indications for rapid sequence intubation? So rapid sequence intubation may be required even in elective surgeries who have adequately fasted, but they have the risk factors for aspiration because of the coexisting conditions like the hiatus hernia or gastroesophageal reflux diseases, or because of the previous gastric surgeries for bariatric surgery. And there is conditions associated with the delayed gastric emptying, the diabetic gastroparesis or chronic kidney disease. So in these conditions, even for an elective surgery, these patients might require rapid sequence induction. So in case of emergency surgeries who have not fully fasted according to the guidelines, or those patients, regardless of the fasting status, who have the risk factors for aspiration. So, for example, the patients who have bowel obstruction and gastric outlet obstruction or upper GI bleeding, even though they are fasting adequately, these patients may require a rapid sequence intubation. And obstetric patients, irrespective of their fasting status, from the second trimester onwards, the rapid sequence intubation is the method of induction in this patient. And the next set of group of population is that the critical care patients, where suddenly you receive a patient who is having an altered consciousness. We are not sure about the status, and these patients are more prone for vomiting because of the head injury. So, and the patients who are in the respiratory failure and who have polytrauma, these patients also require the intubation, a rapid sequence induction intubation. So, is it safe to use rapid sequence intubation? So, what are the risk factors? What are the risks associated with rapid sequence intubation? Yes, it associated with some risks. For example, we apply the cricoid pressure during the rapid sequence intubation. So, it starts before administering the induction agent. So, this may create some patient anxiety because we apply some around 1 kg pressure. So, this can lead to the patient anxiety. And again, the drug administration in the RSSI is that we are using the prefixed drug dosage. We are not titrating to the effect. So the drug can lead to hypotension in these patients. So we have to be very aware that the volume status is adequate, or if these patients might require the vasopressors during the induction that has to be kept ready before induction. And since the classical RSI says that we should avoid giving mask ventilation. So during that 1 minute period, patients who are at risk of desaturation, especially those who with low FRC, so they can desaturate during this type of induction. And the RSI is meant to prevent pulmonary aspiration, but sometimes during this time, the aspiration can occur sometimes because the dose is inadequate or the patient is vomiting. The stomach is actually full and the patient was vomiting. Maybe the vomitus is in between in the esophagus, or during that time, because of inadequate paralysis, that can lead to the aspiration, though it is meant for prevention of pulmonary aspiration. So coming to the method, how to do that. So there is a checklist given by the Difficult Airway Society. It is not actually meant for rapid sequence intubation, but we can take some few points from here that whether that can be utilized in our setting. The things that we can take it from here is that the sequence, the order, the preparation, what they have given is that you have a system for preparation of the patient, and you have a system for preparation of the equipment, and you should prepare the team, and you should have been prepared for the difficult airway during the rapid sequence intubation. So what is the preparation of airway? So the main goal is that to shorten the time to intubation. So that is achieved by the administration of the drugs. So the IV access should be appropriate. So it's not like the line is leaking or the tissued IV cannula, so the drug can leak into the tissues. So that should not be the case while we are dealing with RSI. So there should be an adequate IV access, and you should have optimal positions. We will discuss about the positions while going advanced. Then you should have the thing is that you should have the materials to make the position. It's not like RSI, I have to do it immediately. No, this RSI is to prevent aspiration. So while the patient is coming for surgery, so you should prepare all those things required. Then only you will start doing the things. And as usual, you assess the airway, whether it is an anticipated or it is difficult. If it is a difficult, you have to arrange for difficult airway cord. It may land up with complications. So next comes the pre-oxygenation. So we will go to the pre-oxygenation part. So why is the pre-oxygenation part is important? So as I already mentioned earlier, so when the patient is paralyzed, the patient can develop hypoxemia because of many reasons. So the one reason is that the patient is not ventilating, the patient is apneic, or after the administration of the drug, the patient was hyperventilating for some time, then become apneic after the muscle relaxant, or combination of all these things, or the patient is already having a reduced functional residual capacity, or because of the supine position, muscle paralysis, or because of the distended abdomen, or all these factors contribute to the hyperventilation or apnea, and that leads to the development of hypoxemia. So we have to prevent this complication while doing an RSI. So there comes the role of pre-oxygenation. So the pre-oxygenation is a process of replacing the nitrogen in the lungs with the oxygen, which provides an increased length of time before the hemoglobin desaturation occurs in the apneic patient. So we are basically replacing the air with the oxygen in the lungs. We are filling the oxygen in the functional residual capacity. So this gives the lengthened apnea time for the improved margin of safety while the patient is apneic and during the intubation. So pre-oxygenation. So how do you do the pre-oxygenation? So we use the face mask attached either to the closed circuit with the machine or with the Mapleson circuits. You use 100% oxygen at a very high rates if you are using Mapleson circuit to prevent the rebreathing. The endpoint for the pre-oxygenation is that the end-tidal oxygen should be monitored, and it is desired that to have an end-tidal oxygen concentration more than 90% before starting. And with this technique, the time to oxygen, oxyhemoglobin desaturation below 80% can vary from 9 minutes in a healthy to 3 minutes in an obese patient, or less, or even it is sometimes 1 minute or 2 minutes, even with the oxygenation, pre-oxygenation, it may be very less in the children, neonates, and obese patients. So what are the techniques for doing pre-oxygenation? So one method is that we can ask the patient to take tidal volume breaths through the face mask for 3 minutes, which allows for the exchange of 90% of the air with the oxygen in the lungs. And the method 2, the vital capacity breaths. The patient takes vital capacity breaths. Usually the recommended is 8 breaths over 60 seconds, but sometimes we may not have time in emergency situations where we rely on the 4 breaths over 30 seconds, so which is not effective as the 3-minute tidal volume pre-oxygenation, or 8 breaths over 60 seconds, but it can be accepted in some situations because of the emergency situation. So to improve the pre-oxygenations, we can use techniques like head-up technique, so that it can increase the FRC slightly. So that can also help to increase the margin of safety while the patient is apneic. So how long my patient will not be saturated during the apnea time? So what is the calculation? So why do we do pre-oxygenate? So this is a rough example that if we taken 70 kg normal adult, normal built adult, so we assume that his functional residual capacity is 2.5 liters. And while giving pre-oxygenation with 100% oxygen, so we expect that nearly 95 to 100% of the 2.5 liter will become oxygen now. And assuming that the patient is in the rest, the oxygen consumption at the rest is 3.5 ml per kg per minute, so which is around 250 ml per minute. So this is the basal oxygen consumption rate in this patient. So once the 2.5 liter of FRC is filled with 100% oxygen, now we have the time. The available storage is 2.5 liters, 2500 ml, and the requirement per minute is around 250 ml. So roughly this patient can tolerate an apnea for roughly around 10 minutes. So this range may vary. Sometimes it may be 8 minutes, sometimes it may be 11 minutes. So it is a rough calculation that how the pre-oxygenation helps during the apnea period. So this calculation is made just to understand the importance of pre-oxygenation. So what is next? When the patient is apneic, so the one thing we told that the head-up position improves the margin. So there are certain modifications to improve the margin of safety. So the recommendation is that you use apneic oxygenation. So you are giving oxygen, and once the patient is apneic and you are intubating, you start intubating. So during that time also you can give supplemental oxygen, which is called apneic oxygenation. So there are two techniques. Either if you have the availability of high flow nasal oxygen, so you can use that with high flows around 55 to 60 liters. Or if it is not available, you can even use the standard nasal cannula, nasal prongs with flow of around. Usually we will not go beyond 5 to 6 liters, but in this case, when the patient becomes unconscious, we can go with the higher flows for apneic oxygenation with the nasal prongs. So coming to the equipment and monitoring, so for performing an RSI, the standard monitors should be available, and definitely the ETCO2 should be available to confirm the tube placement. And regarding the blood pressure, so if the patient is unstable, suppose if the patient is a polytrauma patient, or who patient is a septic patient who requires an RSI, so in that case, since we are using the fixed dose of prefixed dose of induction agent, so this can lead to hemodynamic instability. So in that case, maybe we will be preferring to place invasive arterial line or invasive central venous catheter to administer vasopressor infusion in this patient. So the monitoring, the ETCO2 should be the baseline minimum available for doing an RSI. So coming to the equipments, the suction should be available because we are doing this procedure to prevent aspiration. So during this procedure also the aspiration can occur. So that can be managed with the suction. So the suction should be available in a proper working condition, and all the airway adjunct should be available. And in recent years, it is a routine to do RSI with video laryngoscopes in many of the setups. So if you have the availability of having video laryngoscope, so you can better opt for VL-scopy. So next comes the important thing, that you have a team, but without deciding that who will do what. So that will be messed during the thing. So you have to assign a role to each member, that one person will do will be at the head and will be managing the airway. The one assistant can give application of the required pressure, and the team leader, most probably the team leader, gives medications, and he will monitor the whole team, and he will act as a second intubator if the person standing at the head end is facing difficulty, so he can be the second hand for that fellow. And the fourth one, it is optional, but if we have this member, then we will be more comfortable. So runner, if in between, if we need any other help apart from the setup we have already made, so the runner can help us in this situation. So one person will be standing at the head end, and one person will give the required pressure, and one team leader preferably gives the medication, and he will be the monitoring the whole team and gives the instruction. So coming to the required pressure. So the Selig in 1960s, he started telling that this maneuver, giving the required pressure, so decreases the risk of aspiration. So what it actually, how it actually is being done is that you have to apply the pressure on the cricoid cartilage, not on the larynx, not on the trachea. It should be exactly on the cricoid cartilage. So it should be pressed against the esophagus to occlude the esophagus to prevent the regurgitation of gastric content in the pharynx. So it starts from before induction. When the patient is awake, you will explain to the patient that we will give some sort of pressure on your neck. So it will not hurt you, but there will be some pressure. So don't be too much of anxious. So it is normal to do in this type of situation. So you have to explain it properly. So it is around some 10 newtons, which will be around equal to 1 kg pressure. So if you feel that, suppose if I keep 1 kg over my neck, how much the pressure I will feel, that much pressure we have to apply when the patient is awake. And once the patient is induced, the pressure is increased to 30 newton, which is around equal to 30 kg. So if you see here in this mannequin, the cricoid cartilage compresses the esophagus. So this is the hypothesis behind that this cricoid pressure, the Selig's maneuver, that this prevents the escape of gastric content from the esophagus, from the stomach entering into the pharynx. And this is the location. So you have to palpate. So you don't just be in hurry in starting. You can just well ahead examine the patient in the front of neck. You can feel the cricoid before starting the procedure. So that will not compromise, because it has its own drawbacks if the Selig's maneuver is wrongly applied. So there are controversies. So it was in the classical description that the cricoid pressure is one of the must criteria that has to be filled. But the people over the year, they didn't agree to that. The reasons for that, the cricoid pressure results in the decrease in the lower esophageal sphincter tone, and it is actually increasing the risk of regurgitation. This is one group of thought that this leads to the increase in the risk of regurgitation. And this is a very interesting study. I think every one of us might have read about this one. That in MRI suit, they have actually saw that by giving a cricoid pressure, it leads to a lateral displacement rather than compression of the esophagus. So they are doubting whether this has to be employed in this patient. So it's not actually compressing. While in this imaging study, they have found that it's not compressing the esophagus. It's just pushing the esophagus laterally while giving the cricoid pressure. So should we give cricoid pressure? So that was their question. So sometimes everyone might have faced the situations while applying the cricoid pressure makes the situation worse, because it worsens the laryngeal visualization during the laryngoscopy. And sometimes you need to release the cricoid pressure for the optimal visualization of the larynx. And sometimes what happens that it occludes the supraglottic subglottic airway inadvertently if applied. Okay, so it makes the mask ventilation. Sometimes we will come to that part, because in classical RSI the mask ventilation is not advocated, but in some modified techniques, so some mask with minimal pressures, it is advocated to give the mask ventilation. So in that situation, if the cricoid pressure is applied with too much of pressure, because we don't have anything to monitor the pressure, how much we are giving over there, it's a blindly we are giving. Just the pressure is also blind, and the pressure where it is going, that is also blind, so we don't know what is actually happening. So if it is compressing the subglottic structures, so it may actually decrease the mask ventilation in the difficult situation. So provided all these things, so should we avoid giving cricoid pressure? The thing is that all these things are you can easily negotiate. For example, if your laryngeal visualization is not good, you can leave the cricoid pressure in between. And if you're not able to ventilate, you can come down on the pressures you're applying. So that generally it is encouraged to use cricoid pressure, but the controversies exist. And the recent recommendation is a little bit different. We will come to that. And next one, what are the drugs? So as we discussed, that the drug is in a prefixed dose. It's not titrated to the effect. So it is according to the body weight, we will calculate and we will give. So in the classical RSI, the drugs used was thiopentone and dexamethasone. Over the years, so it has been modified. The drugs have been modified. So they tried all their type of induction agents with adjuncts like opioids to prevent intubation response as well. So over the years, it has been changed. But the classical RSI is that you give thiopentone followed by dexamethasone without leaving any time in between these two administrations. So you will not think that I will wait for the 30 seconds for the thiopentone go into the circulation and will produce the sedation, then I will give dexamethasone. No, if you administer thiopentone followed by dexamethasone. So in nowadays, there are so many issues arise about the dexamethasone. So now since the availability of Sugamadex is there, so the people are advocating to go for rocronium. So it can be done with thiopentone, dexamethasone, thiopentone, rocronium. So this is also considered as a standard, provided you have this Sugamadex in hand. So what if I don't have rocronium, or if I have contraindications for dexamethasone? So this is also often we see that patient is having a burns patient, a chronic burns patient, or spinal cord injury, or chronic renal failure patient who comes for some surgeries. We want to do RSA in those patients where the rocronium Sugamadex complex is not available. So, but we want to do RSA. So in that case, what we can do? So we can go with the non-depolarizing muscle relaxant, little bit higher doses, because we know that since the vecronium potency is high, that's why the dose is less. It is 0.1 milligram per kg body weight. So the onset takes much time because of the inverse relationship, the onset and the potency inverse relationship. So it takes more time. So in that situation, you can go for a higher dose, like 0.3 milligram per kg body weight of vecronium can also be used if you don't have any other options for doing an RSA. But provided that will lead to a very prolonged neuromuscular paralysis, so that should be put in mind while choosing those methods. And modifications, yes, over the years it has been modified by so many methods, but so there is no standard definition exists that what is a modified RSI. So it is not a classical RSI. It is not according to the classical technique, but it is different from that. So that may be the definition for RSI, but there is no clear-cut definition exists that what is the sequence, what is the drug with how that has to be given, and what is the timeline. There is no clear-cut definition about all these things. So, but most common understanding is that the modified RSI means that it's a mask ventilation in conjunction with the cricoid pressure during the classical RSI technique. So that makes it a modified RSI. So who are all the candidates for this modified RSI? So there are certain indications that have been even followed widely. So the patients who are at risk for rapid development of hypoxemia. So sometimes you don't have time to pre-oxygenate, or the patient is agitated, or patient is a pediatric patient. patient is not cooperative. So these type of are because of urgency. So you don't have time for pre-oxygenation, and these patients are at risk for desaturation even with pre-oxygenation. But here they didn't undergo pre-oxygenation. So these patients can get benefited while giving gentle mask ventilation during the RSA. And sometimes what happens, we have in short procedure, we have contraindications for drugs depolarizing muscle relaxants. So we have to use the non-depolarizing muscles. And sometimes in extreme situations it can happen. So in those cases, you may be using the low dose, the standard induction dose of vecuronium or atracurium. But for the complete onset, you will have to wait for 3 to 4 minutes. So in that case also, to prevent hypoxemia, you can give minimal ventilation. So which actually the recommended pressure for ventilation during this time to RSI is that it should be the less than 20 centimeter of water. So that makes sense about the modified RSI. So in special populations, so can we do the RSI in all populations? Is it possible? So there are issues with thing that the classical RSI cannot be performed. As I said earlier, that in uncooperative child where there is no IV access is there. So where you can't go with an intravenous induction. So where you rely on the inhalation induction. So in those situations, you cannot really opt for the classical RSI. So you may choose to go for some other techniques. So, and other thing is that anatomical challenges. If you apply in cricoid pressure in the neonate or in the pediatric patient, it's a very pliable airway. So it can even compress the trachea completely, even though the pressure is applied on the cricoid. It can even completely occlude the subglottic region. So which may not be suitable in those patients. And these neonates are especially at high risk, and they are not undergo the routine pre-oxygenation if they are not cooperative and they don't have IV access. So in those situations, if we give the pressure is too much. Even if the slight pressure, even in the adults, we don't have an estimate of how much pressure is given on the front of neck. So in pediatrics, it is really very difficult to decide on the pressures given. So that may compress the airway, and it may be impossible to ventilate those patients. And second thing is that even in adults, the cricoid pressure has to be released in between during intubation because it distorts the vision. So it is more in pediatric patients. So the question of cricoid pressure, the classical RSI in pediatrics is questionable. And they have lower FRC, so that can lead to the profound hypoxemia and bradycardia with even with the pre-oxygenation. Because of the low FRC, they are at risk of developing hypoxemia and bradycardia during this procedure. So what techniques this is also can be called as a modified, but this is not that classical modify. The modification of the classical is only the mask ventilation. So these are all another techniques where you use mask induction if there is no IV access is there, or if you have the IV access, use the IV access and followed by the profound neuromuscular blockade, and you start giving gentle ventilation of it should not exceed beyond 10 to 12 centimeter of water. So this can be an option in the pediatric population. So there is a society called that Project for Universal Management of Airways. Actually, the society is comprised of airway experts. So where they give the instructions, the standard guidelines that how it has to be done, the rapid sequencing to be induction, how it has to be done. So this PUMA gives certain guidelines that certain things are recommended, certain things are suggested, and many things which we discussed are in the optional range. So the recommended has to be followed. It is actually around total 10 steps, so which we have already discussed. So that has to be followed in all cases of rapid sequence induction intubation. And The suggested techniques are like the apneic oxygenation. Actually, it's not a part of the RSA, but it is suggested to improve the apneic time. And yeah, the positional change, as I told, that the slight head up can help in increase the FRP, and that can also help in the decrease in the regurgitation if occurs. And sometimes we may get the patient who have bowel obstruction. They may present with the nasogastric tube. So the thing is that actually, even if you see that the literature says that the presence of an nasogastric tube is in itself an indication for rapid sequence induction. And so if it is there, what should we do? So you do in a good suction and leave it open to the air, and you can proceed with the procedure. So this is the suggested from the Puma. And the optional, the first thing I want to tell about this is the cricket pressure. So we discussed about so many things about the cricket pressure, but now it became optional. So if you feel that you are comfortable with that, and you are okay, then you can go ahead with giving the cricket pressure. Otherwise, even if you're not giving the cricket pressure, that doesn't matter as per this Puma recommendations. So other things like, for example, we give dual prokinetic drugs in CKD patients before going for transplant. So that can be an option to decrease the aspirations, or non-particular intravenous antacids that can be helpful. Or if the patient is full stomach, we can place an nasogastric tube and we can do suction before going for an induction. And better to avoid pre-medications in this patient, pre-medication like sedative pre-medications, especially before induction, because that can worsen the situation. And the thing is that again, they are insisting that you can give minimal mask ventilation during the procedure. So strict avoidance of mask ventilation, we can decide on the case by case basis, but it is not strict nowadays that you should avoid mask ventilation when the patient is apneic. So basically, from this discussion, so if you have noticed that only one thing that comes to my mind, that the inadequate sedation and the inadequate relaxation is the culprit for aspiration during intubation. So that increases all the pressures, that brings the vomiters to the pharynx and leads to the aspiration. So that you have to be very, very sure that that is done. So then it will become very easy task beyond that. So that has to be emphasized. Be aware that RSI means it should be in complete relaxation, complete sedation. It's not an inadequate. I give some, okay, I will give the patient, I will give 125, 150 thiopentone and will do. No, it's not like that. So you give the full dose and do it. And finally, the take home is that, so you identify the patients who are at risk, and you select the patient and you explain the patient, and you take consent for that the patient is at risk of aspiration. So we are doing this procedure, and we will apply some pressure on your neck while you are conscious. So you may feel some pressure. So that has to be identified, and that has to be explained to the patient, and the consent has to be clearly obtained. And ensure that adequate pre-oxygenation is done, and profound paralysis, as I said, profound paralysis is a very must for an rapid sequence induction intubation. And you can have alternate drugs depending on the situations, like etomidate propofol, or you can have using fentanyl, remifentanil for blunting intubation response. These are all optional drugs. If it is available, you can use those things. And be aware of the modifications. It's not always the same technique in all category of populations. The technique may be differing in the different populations. And about the Selix maneuver, so you decide whether to give it or not. But if you are giving, then that should be in a proper way. It's not in like inappropriate way, or non-identified cricoid. You are giving some pressure, no some blind thing. No, that has to be avoided. So if you decide to give a good Selix maneuver, it should be given in a proper manner. And about the difficult airway management protocols, I didn't touch about that part because that is actually different topic. So in RSA, the patient may land up in a difficult airway. So maybe you didn't anticipate because there are no risk factors, but it may turn to be a difficult airway. So in that situation, So in majority of the time, we think that we use choline so that if the patient is not able to intubate and we are ventilating and the patient will come up spontaneous and that will be the safe technique. So that is actually the very bad thinking. Okay, so that has to be aware because this airway management, this RSI is totally depend on the complete paralysis. We do not rely on that. Choline used for difficult airway is a different thing than that is used for RSI is a different thing. So that we have to keep it in mind that it's not the same that for difficult airway that we are using choline so that the patient can become taking spontaneous breath. So that's not the case here. So that's actually detrimental here. So you prepare for a difficult airway because the thing is that you have given a good drug. It has produced a profound paralysis. Now it's the time to place the tube. So that has to be also be very fast. That should not be prolonged. So you should have the equipment ready in hand, so that you will place the endotracheal tube in time. And remember that it's always about cuff inflation. It's a cuffed endotracheal tube and cuff inflation before giving the positive pressure ventilation. Thank you. Thank you, sir.
Thank you, Dr. Sekar. It was a really comprehensive presentation. It was absolutely complete. There was nothing which he had, not talked about. I would like to talk about a few things. Certain things which we don't concentrate on. We know the advantages of RSI, but there are dangers. There are dangers of RSI. Like say for example, a patient who is at risk of MI, at a really high risk of MI. If we give a full dose of thiopentone and the BP crashes and the patient might develop MI, that's a bigger danger than aspiration itself. So patient selection for RSI, it's not just about who requires RSI. It's about where we should modify, where we should avoid RSI. That is also important. So patients at risk of real high risk of hypoxia, maybe it's safer to even take the risk of aspiration. Aspiration pneumonia was a huge problem historically speaking in the older days. In fact, even when I was doing MD, we were taught that aspiration pneumonia has a high mortality. But now it's not the case. Actually, main reason is that we have better antibiotics. Even if the patient has an aspiration, develops pneumonia, it has become much more easier to treat. So that is relatively smaller nowadays. So that's one thing. And another thing is, in the recent past, there have been a lot of studies which kind of prove that Serix maneuver is useless. And I feel really bad about it. I'm a big fan of Selic. If you have read the paper published by Selic about this maneuver, what he had done is it was a cadaveric study. Fill the stomach of cadavers with barium, practically had the cadaver hanging upside down after Selic's maneuver, and not a drop of barium came out. It was checked on X-ray. It was like 100% success. Selic's maneuver prevented contents of the stomach coming out in every single cadaver. It was not like one or two. So it was a really good experiment. But as you pointed out, the esophagus is usually pushed to one side. That is also true. In fact, more than being pushed, it's already on one side. Usually it's on the left, sometimes on the right. It is rarer for it to be in the midline. But in spite of that, Selic's maneuver seems to make a difference. I don't understand how, but Celix does make a difference. The reason why the recent studies show no difference with Celix maneuver, I feel, in my opinion, it's because Celix maneuver is not being done properly. The amount of pressure which requires to be applied is quite high. 30 newtons is not easy. 30 newtons is like hard work. Well, I've seen a lot of when the residents are doing it, they are standing relaxed and it's like just like keeping their hand on the cricoid. That's not enough. There's a lot of pressure, and because this pressure is not applied adequately, one thing, and another because the airway is being pushed to one side, which should not be done proper. salix maneuver, the airway should not be pushed to one side or above or below. So airway becomes difficult. So because of both these reasons, because we are not doing it properly, salix maneuver seems to create more dangers and no advantage. That's my opinion. But obviously studies are showing otherwise. Okay.
And I want to
thank
add
you,
one
Dr.
more
Sekar.
thing, sir.
Yeah.
While since we are talking about the salix, so even in our literature and even in our anesthetic population, so there is a misunderstanding that the burp is salix and salix is burp. So it's not actually true. The burp is actually for to improve the visualization of the glottis during the laryngoscopy. It is not meant to this one. And so when some MCQs, I randomly came through this thing that the salix maneuver, what is that salix maneuver? So in one paper, they have written that it is burp is the salix. So it's not the case. And regarding that, since you talked about the recent studies, so I want to highlight one thing.
Excuse me, moderator, sir. I think once the third person
much time,
finishes that, we can go for discussion because
Sir.
we have to finish that third person let it finish, then we can go for discussion.
Okay, sir. Sir, third
Okay,
person
sir.
will be really quick. Okay, sir, we'll go to the next topic. Dr. Srinivasan, neuromuscular monitoring.
Yes, sir. Good evening, sir. First, I would like to thank the organizing team for giving me this opportunity to deliver this presentation. So today I'm going to deliver a lecture on neuromuscular monitoring. Before I start my presentation, disclosure: no financial support or financial sponsorship from any company related to the content of the presentation was obtained. No conflict of interest, and images used only for academic purpose only. So these are the learning objectives of this presentation: to understand the principles of neuromuscular monitoring, to know the device and stepwise assembly, and to objectively analyze the evoked response using various patterns of stimulation, to incorporate this knowledge into clinical practice, and finally we'll see what the guideline says. So to start with, first we should, before we actually go to the presentation proper, we should understand why we need neuromuscular monitoring during anesthesia administration, mainly to prevent residual paralysis. So if you go to Google and search the literature, incidence of post-operative residual weakness. So don't worry about these numbers, just see this incidence alone. See 50%, 50%, 16%, 30%, 50%, 32%. So if you see the numbers, it is quite huge. Maybe we don't see exactly whether the patient is having a residual weakness in the post-operative ward. But whatever literature is there, the numbers are huge. So what happens if patient has residual neuromuscular weakness post-operatively? You see the literature again, there is 1% incidence of unexpected ICU admissions, around 1 to 5% incidence of post-operative pulmonary complications, reintubation rates, and significant hypoxia, around 30% chances of having diplopia, difficulty in swallowing, muscle weakness, airway obstruction, delayed recovery. All this can present as airway obstruction, aspiration risk, impaired airway reflexes, impaired ventilator response to hypoxia, inability to take deep breaths, and unpleasant feeling of muscle weakness, which all this put the patient at risk of having a critical respiratory event post-operatively. But what we do routinely, we don't use objective neuromuscular monitor for all patients. Traditionally, this is what we are doing, and regularly we are doing this only. Like this patient opens eyes, able to protrude the tongue, patient takes normal tidal volume, sustained head lift is there, sustained neck lift is there, hand grip is there. This is what you routinely follow before extubation. But when these are compared with objective monitors, when TOF ratio is 0.5, patient can lift their head for 3 seconds. They can be able to wide open their eyes. They're able to protrude their tongue. And at 0.7, 0.75 TOF ratio, they can cough sufficiently, able to lift the head for 5 seconds. And if when the TOF ratio is even 0.8 and higher, they will be able to take wide capacity breaths, but they still feel diplopia, blurred vision, and facial weakness. So the clinical assessment alone will not be enough to predict the residual neuromuscular weakness because of the low sensitivity and poor predictive value. So we should monitor neuromuscular function during anesthesia whenever we administer muscle relaxant to prevent residual paralysis, ensure safe recovery and extubation, and to reduce the respiratory complications and to improve the overall patient safety. So having understood why we need to monitor, we'll move on to what is neuromuscular monitor. See, what we're doing here is we are stimulating a nerve, that is motor nerve, and you elicit a response in the muscle to which the nerve is supplying. So that is the basis. Okay. So how does this neuromuscular monitor works? To understand that, we should understand this first. So when you stimulate a motor nerve, you elicit a response in the muscle, the nerve, the muscle which the nerve is supplying. So if you see the response of a single muscle fiber, it follows all or none phenomenon. Whereas the response of the entire muscle fiber, that is the whole muscle, depends on number of muscle fibers stimulated or activated. Okay. So after neuromuscular block administration, some fibers will get blocked. So the muscle response that you elicit after you administer relaxation will decrease in parallel to the number of nerve fibers blocked by the muscle relaxant. So the reduction response reflects the degree of neuromuscular blockage. So this is the basic principle of this neuromuscular monitor. So to elicit this response, you need a constant stimulus throughout the surgery. For that, we need to understand what is called supramaximal stimulation. Maximal stimulation is you give a current, that is maximum current, to elicit maximum response. Supramaximal stimulation is you give a current around 15 to 20% more than the maximum current needed to elicit a maximum response. That is to ensure all the muscle fibers are getting stimulated. So that is supramaximal stimulation. That is beyond that, how much our current you increase, that will be the maximum response you will get. So the purpose of having supramaximal current to elicit supramaximal stimulation is one, to deliver constant current throughout the monitoring process. And number two, as surgery goes on, there are factors like temperature of the skin, which can change the resistance of the skin, which will impede the current transmission across the skin to the nerve. Not to overcome that impedance, you need to deliver much higher current. That is the supramaximal current. Then, next thing, we should understand what is called calibration. So the moment you want to start neuromuscular monitoring, first thing you should need to do what is called calibration. That is, you deliver supramaximal current, you will get a maximum response. So the amplitude of the response should be within the measurement window of the monitor. Whichever monitor you use, it should be within the measurement window of the, that is, it should give 100%. So that process is called calibration. Next, impedance. See, we are not directly stimulating the nerve. We are stimulating the nerve percutaneously. That is, through the skin, you are delivering the current to the nerve. So the skin offers some impedance for the current flow across the skin to the nerve. So in order to overcome that resistance, you need to give higher current. That's why we have chosen supramaximal current. Usually 60 milliamp is used in most of the monitors to overcome a maximum impedance of 5 kilo ohms. Then we need to understand this safety margin. Physiologically, the neuromuscular transmission has substantial safety margin. That is, up to 70% of the new acetylcholine receptors are blocked. That is, up to 70 to 70% are blocked. Patient will not feel any weakness. You see the top ratio here, when the receptors are blocked, even up to 75%, you are getting a top ratio of 95%. So only when the receptors are blocked more than 80% and above, then only patient will start perceiving the weakness and you will get the response in the monitor. That is, you will start appreciating the response in the neuromuscular monitor also. So till 70 to 70% of the blockade of the receptors, there won't be any clinically appreciable weakness in the patient. Now we understood what is neuromuscular monitor. So basically, we are giving a current and you are eliciting the response. That is, you are eliciting the contraction in the muscle. So now we are going to discuss about how you are going to deliver the current. Next part will be how you are going to elicit the response. So now how you are going to deliver the current is the stimulus pattern. So there are multiple stimulus patterns described. See, basically it all started with, it was initially qualitative monitoring. Now it is all quantitative monitoring. So initially it was subjective. Now it is all objective monitoring. So the stimulus patterns also, it all started with qualitative monitors, then gradually it has evolved. So these are the routinely used are all the patterns, different patterns available, patterns of stimulations. Single tube stimulation, train of force stimulation, double burst stimulation, tetanic stimulation, and post-tetanic count stimulation. Now, single tube stimulation is, you will give supramaximum stimulus at 1 Hz frequency. 1 Hz means you give one stimulus for every second. So you will give, this square wave, this waveform is the one stimulus to 1 Hz frequency, and this is the response. This is a normal response, and this is a normal response. When you give a non-depolarizing muscle relaxant, you will appreciate what is something called fade. That is, the twitch height will start coming down as you keep giving the single twitch stimulus. Whereas in depolarizing muscle relaxant, the twitch height will come down and suddenly it will disappear. See, the fade will not be able to appreciate better in your single twitch stimulus. That's why the train of 4 stimulus has come. That is, you will give train of 4 single twitch stimulus, that is 4 supramax stimulus at 2 Hz frequency. That is, every second you will give 2 stimulus. So you will give train of 4 stimulus and you will get 4 response. That is 4 contractions in the muscle. So following a non-depolarizing muscle relaxant, the response to 4th stimulus will be smaller than the first one. That is, you will appreciate a fade here. As the time goes on, the fade increases, and then the 4th count will disappear, then the 3rd count will disappear, then first one also will disappear, and you will get top count of 0. Whereas in depolarizing muscle relaxant, there won't be any appreciable fade normally. The twitch height alone comes down. As it comes down, then suddenly it disappears and then becomes top count of 0. Then tetanic stimulation. That is, you give 50 Hz stimulus for 5 seconds. So you give a 50 Hz stimulus for 5 seconds and you see the response. As the 50 Hz stimulus given over 5 seconds, in non-depolarizing muscle relaxant, you will appreciate the fade as the stimulus is given. Whereas there won't be any appreciable fade in the following a depolarizing muscle relaxant. Now, next comes the post-tetanic count, that is 50 Hz tetanic stimulus for 5 seconds, followed by 3 minutes of pause, followed by single twitch stimulus at 1 Hz frequency for 15 seconds. That is, 15 stimulus will be given. That is, you will give a tetanic stimulus of 50 Hz for 5 seconds, then there will be 3 seconds of pause, and then 15 single twitch stimulus. That is, you will do this only when the top count is 0, then only you need to do post-tetanic count stimulation response. This is to elicit, that is, when the top count is 0, you want to quantify how much is the deblockade. So, based on the response to the post-tetanic count, you decide how deep is the blockade. The implication is, when the PTC count is around 3 to 5, you can predict in another next 8 minutes following vecuronium or atraconium administration, the top is going to be appear. Okay, that will be the implication. Now, next is the double burst stimulation. 250 Hz stimulus of 2 bursts of 3 impulses. That is, each of these bursts there will be 3 impulses. Can you see here? So 3, that is DBS 3 by 3 means 3 impulses of 2 bursts. Each burst has 3 impulses. Of each of them will be 50 Hz. Mainly, this was designed to appreciate fade when you are doing a qualitative monitoring. Mainly for qualitative monitoring, to appreciate the fade, this will be the for qualitative monitoring alone. This will be the better to appreciate the fade. Now we have understood how you are going to deliver the current. Now, after you give the current, muscle is going to contract. Now you are going to see how you are going to evaluate the response to the stimulus pattern. So the response stimulation is the muscle contraction. So that can be evaluated subjectively or objectively. Subjectively by you can see and you can feel the response. That is, tactile can be done and visual also can be assessed. And then objective. Now these days, most of the monitors are objective monitors only. Now, there are many ways of assessing the response. One of the ways mechanomyography, where muscle contraction itself is evaluated. Next is the acceleromyography. Muscle is contracting, so your sensor is attached to the muscle where you are evaluating the response. The contraction of muscle causes movement of the sensor. That movement is evaluated. That is acceleromyography. Next is the kinemyography. A piezoelectric sensor is attached to the muscle where you are releasing the response. The movement of the muscle causes movement in the piezoelectric sensor. That movement is evaluated. That is kinemyography. So you stimulated the nerve. The action potential is generated in the nerve, crosses the neural junction. It conducts across the individual muscle fibers. So the action potential is conducted along the muscle fibers. That action potential is evaluated. That is action potential, the muscle is evaluated in the electromyography. So this is a summary of all these types. That is mechanomyography. The isometric contraction is, muscle contraction is evaluated. This is commercially, none of the monitors available. This is mainly for laboratory experimentation. In electromyography, muscle compound action potential is evaluated. Example is ENMT of G monitor. Acceleromyography, the acceleration of thumb is measured by the sensor attached to the thumb. Example is your top watch. Kinemyography, the movement of the piezoelectric crystal which is attached to the thumb is, that movement is measured. Example is NNMT of the G. And there is one more modality, that is cuff pressure modality. A kind of BP cuff is attached to the arm and brachial plexus is stimulated. The arm muscles are contracted in response to the stimulation of brachial plexus. That causes change in the cuff pressure. That is measured in the cuff pressure modality. Example is Tauf cuff. Now we understood the stimulus pattern and now we understood the response evaluation. Now we need to understand the level of blockade. So this is calibration. That is, you give propofol or any induction agent, thiopentone, you give induction agent, make the patient sleep, because this single twist stimulus is a painful stimulus because you are giving supramaxillary current. So always you do the calibration after the patient sleeps. That is after giving induction agent and before you administer the neuromuscular blocking agent. So first is the calibration and you see the response to TOF. You get all four response, that is TOF ratio of 100. Then you administer neuromuscular blockade. Suppose you give a non-depolarizing muscle relaxant, you will appreciate the fade. That is, you will get TOF ratio, you will get. That is from 100%, it will become 80, 70, 60 like that. It will keep coming down. Once TOF count becomes 0, then TOF will become 0. Once TOF becomes 0, you elicit post-tetanic count. If post-tetanic count is also 0 and TOF is also 0, then it is intense blockade. Suppose PTC start appearing, it is more than 1, but TOF is 0, then it is called deep blockade. If TOF count also start appearing, that is TOF count is 1, 2, 3, then it is moderate blockade. Most of the routinely performed surgical procedures, TOF count of 1 to 2 is sufficient. That much of muscle relaxation is sufficient for surgical relaxation. Then during the recovery phase, again TOF count 4 will appear. Then the TOF ratio will start increasing. Then once the TOF count becomes more than 0.9, you will extubate the patient. That was with non-depolarizing muscle relaxation. That is, you will appreciate the fade. Whereas when you administer depolarizing muscle relaxation, that is when you administer succinylcholine, you won't appreciate fade normally. That is, the TOF ratio will be always 100% till it disappears. Till then, TOF ratio will be completely 100%. Then once TOF count becomes 0, it will become 0. There won't be any appreciable fade in following a depolarizing muscle relaxant blockade. Now we understood the stimulus pattern, we understood the response evaluation and the degree of blockade. Now, how to do this? So first is preparation. You clean the area. Suppose you are going to monitor the ulnar nerve and the adductor polysis response. You clean the spirit where you are going to monitor before you attach the electrodes. You attach the electrodes on the site of nerve which you are going to monitor. Ensure battery is available. It is a standalone monitor and the cables are attached to the electrodes, and you attach the sensor to the muscle you are going to evaluate. And then for your kinemography and acceleromyography, your arm should be untouched because the muscle is going to contract. That contraction is going to be sensed by the sensor, and that movement in the sensor only is going to be evaluated by the monitor. So you need an untouched arm for your acceleromyography and your kinemography. Whereas your electromyography, where your compound action potential is recorded, arms need not be untouched. Even for tucked and for laparoscopic surgery, you can do a electromyography monitoring. And then you avoid stretching of the sensors. And the first step you do is calibration after induction agent. And then regarding sites, so how will you decide the site? Only one thing you need to consider is the site should be, that is the nerve you are going to stimulate and the muscle response you are going to elicit. They should be topographical, that is anatomically distinct, because you are giving a current across the skin percutaneously. It should not stimulate the muscle directly. So the current should be in different, stimulation should be in different place, and the muscle response elicitation should be quite away from the stimulus area. So that is the only consideration you should remember. And most commonly performed is the ulnar nerve adductor polysis. Others are ulnar nerve adductor digiti minimi. This is the ulnar nerve in acceleromyography adductor polysis response. This is kinemography, and this is the electromyography. And this is the adductor posterior tibial nerve and the flexor hallucis brevis muscle. And this is ulnar polysis adductor digiti minimi. This is facial nerve with this corrugator supercilii, and this is orbicularis oculi. Now, coming to the sensitivity of the muscle to the neuromuscular blockade. Why this is important? To decide which nerve you should monitor. You see, onset and recovery, this is the order. Diaphragm, followed by laryngeal muscles, corrugator supercilii, adductor polysis, then the toe muscles, and finally the pharyngeal muscles. This is the onset and recovery. That is, diaphragm is the quicker to onset and quicker to recovery, and the pharyngeal muscle is the late to onset and late to recover. Whereas if you see the sensitivity, that is the resistance, most resistant is the diaphragm and most sensitive is the pharyngeal muscles. But onset is diaphragm because they receive relatively higher blood supply. That's why they are quicker onset and quicker recovery. Now, what is the clinical application? So it helps us to decide when to intubate. That is, you administer the relaxant. When the TOF count becomes 0, you can intubate the patient. And it helps us to decide when to give supplemental dose. Depends on the surgery, how much relaxation is required. Normally, for our convention, like whatever routinely we do, TOF count of up to 1 to 2 is acceptable. So till then, you can wait. And anything 2 and above, you can supplement the dose. And there are some procedures where you need to ensure absolute immobility of the patient. For that, you need to ensure PTC also is 0. For example, aneurysmal surgeries, ophthalmic surgeries, where you need to ensure absolute immobility is there. So you need to ensure PTC also 0, along with TOF also 0. And when to give reversal. So TOF count 4 should appear. Your TOF ratio should appear, then only you start administering the reversal. And then decide the dose of the neuromuscular agent. How much should I administer relaxant? And then when to extubate the patient. When the TOF count becomes more than 0.9, you should extubate the patient. See, this is, if you do all this, the chances of having post-operative residual neuromuscular weakness is very less. But suppose you suspect neuromuscular weakness in the recovery room, even that, for that also you can use the objective monitor and you can see how much is the weakness. Now, based on the TOF response, how to decide how much reversal should I give? For succomodax, see, succomodax is the only agent where even in your intense blockade and deep blockade, you can reverse. That is, you can, for the PTC is 0, you can give succomodax 60 mg per kg. For PTC of 1, that is for deep blockade, you can give 4 mg per kg. For anything, for TOF count of 1 and above, you give 2 mg per kg of succomodax. whereas when you use neostigmine for TOF count of 0, that is, you need to wait TOF count of 4. Then only you should give administer neostigmine, that is 50 mg per kg. If TOF count is 0.4 to 0.9, 20 mg per kg is sufficient. More than 0.9, you can extubate the patient. Now we'll see a video following non-depolarizing muscle relaxation, what happens. So first step is calibration and identifying the supramaximal stimulus. So you will attach the monitors, and then first thing is you are identifying the supramaximal stimulus. For non-depolarizing muscle relaxant, you will attach the first step is calibration to identify the maximum supramaximal stimulus. Then TOF ratio you are identifying. After succinyl administration, you see TOF count is 90%. Then slowly, then the facilitations start appearing. Here you will not see fade. Then immediately go for TOF of 0. Still, see, even if facilitations are there, your TOF is still 100%. Then TOF count has become still 4, and then TOF will become 0. Then you are listening the post-tetanic count. So following a tetanic stimulus of 50 Hertz, there will be 3 minutes pass and you will give 15 single twist stimulus. So this is a tetanic stimulus you are giving, and then followed by 3 seconds of pause, and then you will give 15 single twist stimulus, and here PTC is 1. Then recovery from the depolarizing muscle action. So TOF will be 0, and then the recovery will be like you will start, TOF count will start appearing 1, 2, 3, then TOF count will become 4, and then TOF count will become like 60%, 70%, 80%, then more than 0.9, you can extubate the patient. Now, what does the guideline says? In 2023, ASA, American Society of Anesthesiology guidelines, whenever we administer neuromuscular relaxant, the guideline says we should do objective neuromuscular monitoring. We'll see the strong recommendations. That is, again, strong recommendation against clinical assessment alone to monitor the neuromuscular blockade. And then quantitative monitoring over qualitative monitoring. And then when for extubation, you have to wait till TOF ratio of more than 0.9. And then adductor policies is the recommended site of monitoring, and the recommendation is against the use of eye muscle for neuromuscular monitoring, and succinylcholine is should be used for deep blockade compared to neostigmine. So the take-home message: quantitative neuromuscular monitoring is superior compared to your clinical assessment, and qualitative monitoring. Whatever device you use, you get familiar with the device and know its limitation. And depends on the indication, appropriate selection of the stimulus pattern should be done for whatever purpose you are using. Thank you.
Thank you, Srinivasan.
Thank you, sir.
It's a really good presentation. You told us about many techniques, right? Many techniques like acceleromyography.
Yes, sir.
Electromyography.
Yes, sir.
If given a choice, which one will you choose? Which is the best?
Sir, actually, there is no superiority, sir. It depends on purpose. Like, it depends on availability and purpose. And if any monitor, if we could do properly, that is, you maintain the skin temperature and prevent the hypothermia, and you properly like the hands are untouched, and so there is no superiority. Like among the given options, there is no superiority, sir. And if personally, out of my experience, I would prefer kinemography, sir. Out of whatever, like I've used all three, sir. I have found this acceleromyography, like compared to acceleromyography, the kinematography gives most of them like predictable response most of times. Like out of my experience, I'm telling, sir.
Okay, I think the best monitor will be one which does not give artifacts.
Maybe
Artifacts.
that, yes, sir. Maybe that was the one reason I felt like why it is not, even it is available, why it is not commonly used, because we don't get always the expected response.
Okay, how about phase 2 block in?
Yes, sir. In phase 2 blockade, we will be appreciating the fade. After succinyl choline, if you appreciate fade, then it indicates phase 2 blockade, sir. That can then the top we will be seeing the fade in the top, sir.
Okay, so what do we do then?
Actually, textbook says you can try reversal, but we cannot predict the response to the reversal. So best would be we have to wait for recovery by itself and then extubate, because the response in neosequence may be unpredictable.
Okay. Have you had the experience with this? Have you given neostigmine?
Following phase 2 blockade, like I've never had phase 2 block. Like once we had phase such situation, like we had given neostigmine and extubated the patient. Following which patient had spasm and we had given full dose of succinyl choline. We had to ventilate almost 2 hours, but we did not give the repeat neostigmine. We had to ventilate almost 2 hours and then we extubated the patient.
Okay. So best thing to do on phase 2 block is just wait it out, right?
Yes, sir. Yes.
Thank you, Srinivasan.
Thank you, sir.
Sekar, there are a few questions for you.
Yes, sir.
About RSA in pediatrics.
Yes, sir.
Is there an age from where you would start recommending RSI, or can it be done at any time, any age?
No, sir. There are no certain guidelines regarding the age. So it's about the risk of aspiration. So in any patient, so if we feel that there is a risk of aspiration, then we should opt for RSI.
Okay. Generally, the cartilage in newborns and all is quite soft. So actually, the risk-benefit ratio switches. I mean, the risk is much higher in neonates.
That's what, sir. That's what I told that regarding the issue with the cricoid pressure. So that's why I think the Puma recommendation is it's optional now. So if it's not actually the patient is getting benefited from cricoid pressure, we are not sure about that. So especially in the vulnerable population with pliable airway, the neonates, we usually avoid, because that will worsen the view also. So rather than it's compressing, so it's worsen the view most of the times. So we need to release the cricoid.
So generally, there is a...
Srinivasan, please stop sharing your screen.
Okay, so generally, this cartilage, cricoid cartilage, becomes hard enough like an adult around 8 years of age. So there is no fixed age, as Dr. Sekar pointed out. There is no recommendation on this from what age cricoid is to be given. In fact, there are a few recommendations about how much pressure to apply in neonates, how much pressure to apply in babies. But as pointed out by Dr. Sekar, the risk of Selix maneuver seems to be high and can actually
sir, the technique of applying Selix is that with one thumb on one side and the other 2 fingers on that side, compressing along with the skin. It's not that we are placing the one finger on the maximum circumference of the cricoid so that it will go like this. It's like you're compressing along with the skin. It's like posterior. The pressure is towards the posterior. It's not towards the center of the trachea. So, but still, in pediatric population, it's very unpredictable, because the cartilages are very soft, and it's not only because our hands are also very big. The neonate front of neck is very small, and we will compress. Even if it is not compressing, we think the most of the subglottic area is getting compressed, and that creates an issue.
So that is the reason why he is asking straight question. Yes or no? Whether it is practiced in pediatrics. I have never seen it is being practiced in pediatrics. That is
Pediatrics,
what
yes, sir.
Dr. Muthukumar Rajagopalan wants to know. Because you have specifically talked about RSI in pediatrics, he wants to know that. So,
Sir, RSI in pediatrics, classical RSI is not possible.
however,
So the
that's
thing
all.
is that,
That is the take home
that's not
message.
possible.
That is the answer.
Yes.
That
No
is the
RSI
answer,
in
that's all.
babies.
Because from the induction itself, if there is no IV axis, then the child is not cooperative, then we are stuck.
He has asked the second question also.
So the second question is, how do you know how much pressure you are applying? How do you know?
Sir, it is a subjective thing. So that is also an inherent issue of the cricoid pressure. So when in a conscious patient, it's very easy actually that if the patient feels more pressure, we can come down. We feel that okay, that we tell that this is minimal pressure you will feel. That the patient says that no, the pressure is too much, we can come down. But once the patient is induced, we may not be able to control the pressure how much we are giving. Maybe most of the time it may be inadequate or it is too much. So optimal thing, there is no clear cut thing. How do we measure this? Not but study purpose, there are measurements, equipments are available, but for routine practice, it's not used.
So actually, it is not possible to know how much pressure we are applying.
Yes, sir.
What I do is whenever I go to shop and I see an electronic weighing machine, I put my finger and put a weight of up to 3 kg. It has to come to a weight of 3 kg. So I keep doing this every time, and so I know how much pressure. That's why I was pointing out, right, that it's a lot of effort. 3 kg, putting a weight of 3 kg with one finger, the index finger, is a lot of work. So you can see the person giving Selix is giving some effort. So in fact, you can say as much effort as possible, as much pressure as possible, unless you're huge, muscular and all, you can give as much pressure as possible and it will be right. But 30 newtons to measure, there are devices to measure pressure in terms of newtons, but practically we cannot use those in the clinical situation. Yes.
So if there is an inadequate anesthesia and then the patient attempts vomiting, can it lead to rupture of esophagus? Is there any possibility?
Yes, sir. That is the biggest disadvantage of giving too much of pressure with the cricoid, sir. Because actually that is the situation. If we are sure that the patient is full stomach, it's better to put an nasogastric tube, decompress the stomach, then remove the rail tube, then proceed with RSA. That is the most ideal technique in this situation. Because if the patient vomits during that time because of inadequate sedation and we are applying pressure, definitely that's lead to the esophageal injury.
In fact, that was a standard recommendation from Selig. What he used to practice is, even if the patient does not have a rail tube, we will put a rail tube, empty the contents, and then remove the rail tube. Because the concept is that a rail tube inside the esophagus is going to keep the esophagus patent. So he used to remove it. But then later the concept changed. The rail tube can remain inside. So if a patient has the rail tube, we aspirate the contents.
And yes, sir. If the rail tube is in place, then that has to be sucked before doing the procedure, and it has to be left open so that even if some contents are coming, that should have at least resistant pathway to come out.
But it is not recommended to place a rail tube just for the sake of decompressing the stomach. And it is not recommended to remove it. We leave it open. Dr. Prasanna, I have one question for you.
Yes, sir.
We know about the implications of hypoalbuminemia in when we are using pipe and tone. Say a lot of fractional drugs. Which drugs which we are presently using cause problems for us in hypoalbuminemia patients? What are the implications?
As this we face more in the CKD or the CLD patients where they're more prone for hypoalbuminemia. The current drugs which we use, both the thio and the propofol, both has the highest protein binding effect, sir. Whereas propofol has the highest, the peak. It has 90 to 95% of the protein binding than the thio. So even giving a propofol in a hypoalbuminemia cases is also controversial, sir. But its elimination is faster compared to thio, so it is a preferred drug in a patients with hypoalbuminemia, sir.
Okay, the problem with these short-acting drugs is not a major one. The problem comes when the drugs act for a longer period. That's when we face problems. as you pointed out, propofol is much more protein bound, more albumin bound than
Yes.
thiopentone. Midazolam is also a problem. Midazolam can have more intense effect. It also has a high protein binding.
Yes, sir.
And is there any other disease like acute intermittent porphyria, like for thiopentone and acute intermittent porphyria? Is there any other anesthetic drug where you want to avoid in certain situations?
I couldn't think of any now, sir. Like any.
Okay, this is the most famous one, right? Acute intermittent porphyria.
Yes, sir.
Okay, thank you, everyone. I'll hand over to Dr. Meenakshi, sir, for closing.
Thank you very much. Because it is a basic topic which we wanted to cater, because everyone wants to do only ultrasound guided nerve block, and the postgraduates also think only that ultrasound guided nerve block is the anesthesia. They have forgotten that the spinal epidural is also there, and again they say to identify spinal space and extradural space, ultrasound is used. So now, because of the corporate hospitals, anesthesiology postgraduates are crazy about nerve block, and because the repeated workshops are conducted, they have forgotten the basics, that is thiopentone and propofol. Previously, we have requested one PG to talk on propofol. Again, that PG is also from Puducherry, but from Mahatma Gandhi Medical College. So now that PG has covered, Lakshmi Prasanna has covered very well about this thiopentone, and Dr. Sekar has given a good discussion on rapid sequence induction, and that is the reason why questions are also there, because it is commonly practiced. And the neuromuscular monitoring, even though majority, I think 90% of the people are not doing neuromuscular monitoring, especially after the advent of vecuronium and atracurium. If some problem happens, they are going for post-op ventilation. But even now, the neuromuscular monitoring, this has to be encouraged. It has to be widely used, and it was perfectly monitored by Dr. Mohan, a kind-hearted gentleman. So we thank all the 4 people for taking part in our Pudukkottai Bhudhan. And now I request Clearnet to pass the concluding remarks to close the session.
Thank you so much, everyone, for joining this session. Clarinet is really glad to have all these brilliant people together. So with all your permission, I'm closing the session for today. Thank you so much, everyone.
Thank you. Thank you.
Thank you.
Thank you, sir.
Thank you, sir.